This is the sepsis education for the RGH ED nursing staff. The objectives is to define sepsis and SIRS, identify cause and risk factors of sepsis, describe the scope of the sepsis problem, identify the surviving sepsis campaign care bundles, and discuss the new adult ED nursing sepsis protocol and its impact on nursing. The goal is to improve the timely management of patients presenting to the ED with potential sepsis by implementing a sepsis protocol for nurses. Let's first define sepsis. Sepsis is a serious illness or clinical syndrome caused by an overwhelming response to an infection. A majority of cases are due to bacterial infection, especially gram-positives, followed by gram-negatives. Fungal and other microbes can cause infection, but are less common. The body responds to the insult or infection by triggering the immune system, causing a cascade of inflammation. Common sites where infections may start are in the lungs, such as pneumonia, urinary tract, such as UTI and pyelonephritis, in the abdomen, and in the skin, such as surgical sites, central lines, cellulitis, ulcers, or any open wound or MRSA infection can cause sepsis. It is critical to recognize the stages of sepsis. Sepsis can mimic other conditions, making it difficult to diagnose in its early stage. SIRS is an early stage or sign of sepsis. SIRS is short for Systemic Inflammatory Response Syndrome. The body responds to the insult or infection by triggering the immune response. Immune chemicals are released to combat the infection and triggers inflammation, thus its name. SIRS is defined by two or more of the following criteria: a temperature greater than 38 degrees Celsius or less than 36 degrees Celsius, heart rate greater than 90, respiratory rate greater than 20, or white blood cells greater than 12,000 or less than 4,000, or greater than 10% ban. Since we rarely have elevated white blood cells on arrival or unable to see that until labs are drawn, the RGH-ED has added additional SIRS criteria, which includes systolic blood pressure less than 90, mental status change, and oxygen sats less than 90%. Remember that other factors can elevate or lower your vital signs. For example, beta blockers can lower heart rate, so patients with sepsis may not always present with an elevated heart rate. Or a patient with recent albuterol treatments in the ambulance will present with an elevated heart rate but may not have sepsis. It is important to evaluate the situation. The second stage after SIRS is sepsis, which is defined as SIRS and a confirmed or suspected infection. Third stage is severe sepsis, which is defined as sepsis and signs of end organ damage, hypotension, and a lactate greater than 4, and urine output less than 30 mLs per hour. The last stage is septic shock, which is severe sepsis with persistent hypotension. These are patients that you're constantly giving fluids and they still have a low blood pressure, and signs of end organ damage and a lactate greater than 4. Anyone can get sepsis. The risks are higher with those who are immunosuppressed, such as HIV, cancer, and chemotherapy patients, patients with invasive catheter access or drains or medical procedures, patients with chronic illnesses or conditions, those with severe burns or trauma, infants, children, and elderly, a history of resistant infection, community-acquired pneumonia. 48% of these patients progress to severe sepsis and 5% to septic shock. Note that sepsis due to nosocomial infections have higher mortality than community-acquired infections. It is expected that there will be 750,000 cases of sepsis per year in the US, affecting 18 million worldwide. It is also expected to grow to 1 million cases per year by 2020. This is a graph from the CDC, which shows that from 2000 to 2008, patients hospitalized for sepsis more than double in the US. Sepsis still contributes to 1 in every 2 to 3 deaths in the hospital. It is the leading cause of death in the ICU, second to MI. In 2011, septicemia in U.S. hospitals was the #1 most expensive reason for hospitalization. It cost $20.3 billion in the U.S. The annual cost of sepsis is expected to rise 1.5% per year. Mortality rate is 28 to 50%, and the rate of mortality increases by 7.6% for each hour that antibiotics are delayed. This is a quote from a CEO of a large medical group. Sepsis kills more than 210,000 Americans each year, equal to the population of Rochester, New York. This puts it into perspective. He also states that sepsis-related deaths and serious consequences are preventable for as many as 30% by a simple blood test. Sepsis kills more people than HIV/AIDS, prostate cancer, and breast cancer combined. From 2005 to 2011, sepsis cases increased 41%, and severe sepsis cases increased by 68%. New York State mortality ranges from 15 to 37%. This is a picture of Rory, who died of sepsis in 2012. Rory's father sums it up with a statement. There's no reason in today's world why a 12-year-old boy would fall in gym, cut himself, put on a Band-Aid, and 4 days later be dead. Rory played basketball at school, got a cut. And the family provider and hospital diagnosed it with a stomach virus. And by the time the blood tests were examined and family was contacted, this infection had spread. Through Governor Cuomo's sepsis initiative, New York State Department of Health passed Rory's regulation. The purpose of this law is to provide clinicians with the tools and processes they need to quickly identify sepsis and begin treatment. The growing sepsis problem prompted the establishment of the Surviving Sepsis Campaign in 2002. The Surviving Sepsis Campaign is comprised of 68 international experts who developed guidelines and bundles. These guidelines and bundles were published in 2004, 2008, and 2012 and are time-specific and focus on early identification and treatment of sepsis using bundles and protocols. The most recent 2012 guideline emphasized a quicker return of lactate levels and obtaining blood cultures before antibiotics are given, which have direct implication for nursing care. Nurses have a direct impact on identifying sepsis and ensuring prompt diagnostic blood samples. Nurses draw the labs and initiate antibiotics. As you see here, within 3 hours of severe sepsis, the recommendation is to measure lactate level, obtain blood cultures before antibiotics, administer broad-spectrum antibiotics, and administer fluids. The most recent update, as of April 2015, revised the 6-hour bundle in Step 6 and added a Table 1. This is a small change that affects providers. If you're more interested in this change, refer to the Surviving Sepsis Campaign website for further information. Some of the research behind sepsis management includes the landmark study by Rivers that uses randomized control trial to determine the effects of early goal-directed therapy for patients with severe sepsis. This study introduced early goal-directed therapy, which includes IV fluids to maintain CVP of 8 to 12 and vasopressors for a MAP less than 65. The result of the study found a significant decrease in mortality rate in early goal-directed therapy group versus control group. This study has been cited numerous times in subsequent research on sepsis. Many studies show the use of sepsis protocol or order sets improves early identification of sepsis. Earlier identification leads to earlier treatment and resulted in early goal-directed therapy initiated sooner, time to administration of antibiotics decreased, variability in practice was reduced, and compliance improved. Mortality rate was reduced. Atkins' study used best available evidence in surviving sepsis campaign guidelines as a framework. The article provided 63 recommendations related to nursing care of sepsis. The authors recommend that all staff be educated to recognize SIRS. This is one of the objectives of this presentation. They recommend the use of early sepsis recognition tool. They also note that early detection of high lactate levels helps with early recognition. A delay in turnaround times greater than 1 hour is dangerous. A research study by Trump in the Netherlands developed a protocol that allowed nurses to take diagnostic labs such as chemistry, lactate, blood cultures, and urinalysis before a provider assesses the patient. The study resulted in early identification and treatment of patients with sepsis and improved compliance. Mortality was also decreased. A study in New Mexico used a screening tool for nurses that allowed nurses to assess for sepsis and draw lactate, then notify a provider to initiate order sets to obtain further blood samples and start antibiotics. This resulted in decreased mortality and increased nursing satisfaction. A survey of physicians conducted at the American College of Emergency Physicians conference found that 93% of the time, the most difficult aspect in diagnosing sepsis are due to overlapping symptoms and vague symptoms. Sepsis can be difficult to diagnose because early signs can mimic many other conditions. It can quickly progress to severe sepsis and septic shock. Therefore, diagnosis and treatment needs to happen as soon as possible. The new ED nursing sepsis screening protocol is needed to help identify sepsis quickly. A survey of physicians in the Infectious Disease Society of America meeting were asked about how important the speed of lab results for microbial identification tests to patient outcomes were. 98% of physicians found it very or critically important. When asked how important the speed of lab turnaround time is to determining antibiotic treatments, 96% felt it is very or critically important. The speed and turnaround time is important, which the new nursing sepsis screening protocol will help obtain labs sooner and hopefully result in a quicker turnaround time. Early identification of sepsis is key. It can delay or halt the progression to severe sepsis or septic shock. Sepsis is similar to stroke, MI, or trauma. Time is tissue. The longer it takes to identify sepsis, the more tissue damage occurs. Lactic acid levels are elevated in sepsis due to tissue injury. Early lactate can help with early diagnosis. The speed and appropriate treatment, such as fluids, antibiotics, early goal-directed therapy in the initial hours may likely improve patient outcome. Suspect sepsis saves lives. This is the original tool in current practice. Once the patient is screened positive for 2 or more of the SIRS criteria, a provider is notified and IV access and diagnostic labs are ordered by the provider. This is the new adult ED nursing sepsis screening protocol. This is a one-step change from the original. It allowed nurses to place an IV and draw necessary labs immediately after the patient is screened positive for 2 or more of the SIRS criteria, which we have mentioned earlier. If the patient is screened positive by the nurse then can enter order sets in CareConnect to obtain diagnostic labs to be drawn and sent before a provider sees the patient. This only affects the adult ED and EMS triage, where a provider is not easily available to quickly examine the patient. This is a helpful mnemonic to remember the sepsis protocol. S. Screen for sepsis and start the sepsis protocol. E. Enter orders for labs, EKG, and cardiac tele. Remember that lactate is a gray top placed on ice and is the last tube without a tourniquet. Leaving a tourniquet on for more than 2 minutes can cause falsely elevated lactate level. P. Print the lab. S. Send the lab. I. Inform the provider of a positive screen for sepsis and request orders for IV fluids and antibiotics. Yes, the providers still need to be notified. They have their own sepsis protocol to follow. S. Start the first dose of antibiotics within 1 hour and complete fluid resuscitation within 6 hours. Give IVP push antibiotics such as ceftriaxone first, then the shortest infusion antibiotics such as Zosyn, vancomycin, or gentamicin last if ordered. These take longer to infuse. Why is a sepsis protocol needed? The treatment of sepsis is time dependent. ED nurses play a critical role in sepsis care. ED nurses are first to triage and first to potentially identify sepsis. The Surviving Sepsis Campaign guidelines in 2012 emphasize a quicker return of lactate levels and obtaining blood cultures before antibiotics are given, which affects nursing care. The rate of mortality increases by each hour antibiotics are delayed. Because of Rory's regulation, New York State requires all hospitals to adopt best practices for early identification and treatment of sepsis. Sepsis protocol is also needed because evidence-based research shows that early identification of sepsis and earlier treatment improve outcomes. Protocol or order sets are effective in improving timeliness of care by reducing variability of practice, improving timeliness of antibiotic administration, initiating early goal-directed therapy sooner, and reducing mortality rates. Key points to remember is that time is tissue. The first hour can be critical. Nurses in ED play an important role in sepsis care. Nurses need to screen for sepsis using the adult ED nursing sepsis screening protocol to help with early identification. If 2 or more SIRS criteria are identified and a provider is not available, this protocol allows nurses to obtain an order set to place an IV and draw labs, then notify a provider to start IV fluids and antibiotics as soon as possible. The new adult ED nursing sepsis protocol is useful in areas such as EMS triage or at times of overcapacity, when a provider is not readily available to assess the patient and place orders. Thank you, and this completes our sepsis education. These are references available to you for further detailed information. Congratulations.